of disability worldwide. It's not cancer, it's not heart disease, both of which have enormous public awareness, receive millions of dollars or euros in research funding. It's actually depression. A well-known Danish psychiatrist said recently in a newspaper article that depression is a toneless, infinite suffering with a strong sense of hopelessness and meaninglessness, guilt and thoughts of death. So, in my opinion, this is a very hard place to be. Previously published projects about depression and recurrent pregnancy loss are usually quite small, based on interviews and have a lack of control group. Depression is not very well, stress is not very well studied in recurrent pregnancy loss, but a recent small study showed a higher prevalence of emotional stress among patients with recurrent pregnancy loss compared with fertile controls. 10 years ago, there was a population-based study of stress and depression in the general population in Denmark was published and showed that in the age group of 20 to 49 years, the prevalence of depression was about just less than 4% around for women, and the prevalence of high stress levels was about 20%. We might define recurrent pregnancy loss in different ways, but we all agree that it's something that repeats itself, that it is a disease defined by a repetitive nature. And it's not known how this repetitive nature of the disorder affects the emotional adjustment to it. Some say that the couple sort of gets numb and gets used to this, whereas others say that as it is repetitive, the couple is unable to process one loss before the next occurs, and this might, in theory, lead to stress and depression. So based on a clinical observation in our own clinic that both the man and the woman suffer greatly from their recurrent pregnancy loss, we decided to study whether the prevalence of depression and emotional stress is higher among women with recurrent pregnancy loss than women trying to conceive naturally. So in the period from 2010 to 2013, 438 women were referred to the Danish Pregnancy Loss Unit. After their information meeting, which, as Louise said yesterday, takes place before the first consultation, they received an invitation by email to participate in this online study. 137 declined or did not respond. So we included 300 patients, which was just about 69%. The comparison group is part of an ongoing online survey called the Soon Parent Study, which tries to investigate the impact of lifestyle factors on fertility. It was started in 2011 and includes couples who are trying to conceive naturally. So these are not infertility patients. When we extracted the data almost a year ago, 2,226 women had filled out this online survey. We had to exclude 412 because they didn't answer all the questions we were interested in. So our comparison group comprised 1,800 women. For measurements of stress, we used the Cohen's Perceived Stress Scale, which is a validated and probably the most widely used instrument to measure self-reported stress. It's designed to measure how unpredictable, uncontrollable, and overwhelming the respondents find their lives. So they're asked how much of the time during the last month have they felt this, ranging from never to very often. For this study, we used a cutoff of 18 to denote high or low stress, because 18 was the 75th centile in the comparison group. The Major Depression Inventory is also a psychometric scale here for depression, and it was developed to directly correspond to the ICD-10 classification of disease, and it also covers all the terms in the DSM-4, including an additional item of low self-esteem. It can be used both as a diagnostic tool, where you use this demarcation line. Sadness, loss of interest, and lack of energy are what's in the ICD-10 called core symptoms, and the rest of the items are the accompanying systems. It can also be used as a measuring instrument like the Hamilton Depression Scale, where you just use the sum of scores and 20 denotes some degree of depression. The recurrent pregnancy loss patients were significantly older and had significantly more previous pregnancies than the comparison group, which is not surprising as they are, of course, selected by having at least 3 pregnancy losses in their history. We also found that the patients were significantly more well-educated and had a higher household income than the comparison group. The mean score on the stress scale in the pregnancy loss patient group was 16.17 and significantly higher than in the comparison group, with a mean difference of 2.7. And we found that high stress in the unadjusted analysis, the odds ratio for high stress in the pregnancy loss group was 2.34, and when we adjusted for the various demographic factors, the adjusted odds ratio was 1.59. The RPL patients also scored higher on the MDI than in the comparison group. And we found, when we looked specifically at moderate to severe depression, so not light depression, we found in the unadjusted analysis an odds ratio of 4 for depression in the patient recurrent pregnancy loss group, corresponding to a prevalence of almost 9%. And when we adjusted for age, education, household income, number of live-born children, and number of prior pregnancies, the odds ratio for depression in the pregnancy loss group was 5.5. So if you want to read more about this, it's in second review of human reproduction, and we are really hoping that it will be accepted. After we submitted it, I heard about a study on the prevalence of depression after IVF, whether the women the couple had a child or not a child. So we tried to look at, okay, what happens with our patient if they have secondary recurrent pregnancy loss, meaning a child before the series of miscarriages. Are there emotional distress? Is it lower? Is it the same as those with primary recurrent pregnancy loss? And we actually found that the women with recurrent pregnancy loss who have a live-born child, they had a lower prevalence of depression, and we didn't find it in the comparison group. So in conclusion, from this baseline study, we found that women referred for recurrent pregnancy loss have high levels of emotional distress. We also find that the respondents in the Soon Parent study, which, as I said, are women trying to conceive naturally, report the same prevalence of depression and stress as the Danish general population. And that moderate to severe depression among women with recurrent pregnancy loss is less likely when they have a live-born child first. So, as I said, we sent a primary questionnaire to the 300 participants who filled out the primary questionnaire before their first consultation. We sent them an invitation to participate in a follow-up 1 year later. And 60% responded and 116 didn't. So we have scores of emotional distress both at referral and 1 year later for 185 participants. But for the non-responders, we have reliable data on pregnancies after referral for almost all of them. So in total, 287 patients. Okay, so first of all, we wanted to look at, okay, does MDI and PSS score have any impact on whether the couple has a live-born child or an ongoing pregnancy after 1 year after referral? And we didn't find that PSS at referral had any impact on this, and the same with the MDI. But then we looked at the change of PSS scores from referral to 1 year later, and we found that in the group of women who within the first year after their primary consultation, the mean difference from referral to follow-up was 4.4 points on the PSS scale. which was significant, but there was no significant change in the no live or ongoing pregnancy group. And the difference between the live birth group and the no live birth group was significant. And when we looked at the same about changes in MDI scores from referral to 1 year later, we again found that this the mean difference in score on the MDI was significantly lower 1 year later for those who had had a live birth or an ongoing pregnancy, whereas we didn't see any change in the group who had not had a live birth or ongoing pregnancy, and this was also significantly different between these two groups. So in conclusion, first of all, we can see that live birth rate or ongoing pregnancy rates are quite high. After 1 year, it's almost 50%. And we also saw that, at least in this study, the scores on MDI and PSS were not predictive for the chance of live birth or ongoing pregnancy after 1 year, but that if they do have a live birth or an ongoing pregnancy, then they have a lower level of emotional distress 1 year after referral. So, to take home, stress and depression is highly prevalent among patients with recurrent pregnancy loss. Emotional distress decreases with a live birth, at least in the first year. And then the point for discussion, how do we provide these patients with the best care? Because as Louise Lune told us yesterday, the recurrent pregnancy loss unit here in Copenhagen is basically a tender loving care clinic. So we provide these patients with repeated ultrasound and emotional support when they are pregnant. But what about those who are not pregnant? How do we provide the best care for them? It seems that at least some of these patients have a need for emotional support or maybe even treatment for depression also when they're not pregnant. I'm not saying we should do it as gynecologists and nurses, but it's something to bear in mind. These are my collaborators, Ellen Mikkelsen, who's the senior investigator in the Soon Parent study, Lise Olsen, a psychiatrist who did the population survey in 2004 and who provided all the questionnaires we used, and then of course Ole Christiansen and Henriette Svare Nielsen. So, thank you.